Hello, I am Jermaine Reed, and I'm a board member of the Fibroid Foundation. Thank you so much for joining us during Fibroid Awareness Month, centered around our theme, the fibroid maze, finding solutions for a complex diagnosis. In addition to being a board member, I am also a fibroid warrior. I was diagnosed and had surgery in 2020 to remove most of them. Early in my diagnosis, I found the Fibroid Foundation through social media while searching online for answers at 2 a.m. From the beginning, I felt genuinely supported through the Foundation's free education resources, access to the latest peer-reviewed research, and an extensive network of global ambassadors who volunteer their time to offer guidance and support from their own fibroid experiences. We hope you enjoy the programming created for you throughout this important month. We invite you to donate so that we can continue to support everyone in need at thefibroidfoundation.org. Join me in supporting the Fibroid Foundation. Together, we can make a difference.
Hello, I'm Sateria Venable, founder and CEO of the Fibroid Foundation. Welcome to Fibroids Awareness Month 2024. Can fibroids mask other issues? Good question. In some cases, the presence of fibroids might complicate the diagnosis or management of other conditions. For instance, fibroids could make it more challenging to detect an ovarian cyst or to assess the uterus clearly in imaging studies. It's important to consider the possibility of coexisting conditions and to conduct a thorough screening when a patient presents with symptoms that could be attributed to uterine fibroids. This ensures that any underlying health issues are properly identified and managed alongside the fibroids. As a patient, we need the knowledge to ask our providers the important questions to assure that our diagnosis is complete. What are those questions? And are there warning signs to discuss with our providers? Today, I'm pleased to be joined by two renowned physicians who specialize in the treatment of uterine fibroids to begin this much-needed conversation. Dr. Linda Bradley is an internationally recognized gynecologic surgeon and vice chair of Cleveland Clinic's Women's Health Institute. She holds innumerable publications and teaching awards, and in addition to many leadership positions in national organizations and at Cleveland Clinic. Dr. Bradley is a member of the Fibroid Foundation's Medical Advisory Board and Medical Director of the American Association of Gynecologic Laparoscopists, or AAGL. Dr. Jones-Cox is the Chief of Women's Health Services at the Walter Reed National Military Medical Center. Dr. Jones-Cox is a fierce patient advocate and a meticulous surgeon, passionately learning cutting-edge techniques to adapt to an ever-changing medical landscape. Dr. Bradley, Dr. Jones-Cox, thank you so much for being with us today.
Thank you for the invitation. Glad to be here.
Thanks for having me as well.
So I'll come to Dr. Jones-Cox first with the first question. If a woman or menstruator is diagnosed with uterine fibroids, what other screening should they expect?
When a patient is diagnosed with uterine fibroids, it may be an incidental diagnosis, or there may have been some history that prompted some evaluation that led to the diagnosis. But initially, they should have a thorough history and physical by their provider discussing some of the symptoms they may or may not have secondary to their fibroids, whether that be heavy menstrual bleeding, whether it be bulk symptoms like urinary frequency or constipation or pain with intercourse. Imaging typically starts with a pelvic ultrasound, and in some cases, we also may need additional imaging like an MRI. And then we start with some basic laboratory evaluation as well, like a blood count to assess for anemia, iron panel, renal function, just to get an idea of the significance of the fibroids and how it may be affecting other systems.
Thank you for that. And I always like to ask, what are bulk symptoms? Because I think that those symptoms are glossed over unknowingly by a lot of patients.
Yeah, bulk symptoms, because fibroids grow so slowly, oftentimes women kind of normalize this feeling that develops over years. So bulk symptoms can be a pelvic pressure or heaviness. It can be symptoms caused by pressure on pelvic organs, like urinary frequency, urinary incontinence, constipation due to pressure on the colon. Some may even have pain with intercourse due to discomfort during intercourse from the bulk of the uterus. So it can be sometimes difficult to tease out and for people to actually understand if they're having those symptoms.
Thank you for that. And Dr. Bradley, what screening should patients expect?
I totally agree that patients need an excellent history with really outlining a lot of in-depth questions, whether the doctor asks or the patient themselves should volunteer. We look at sharing with the history. Periods should not bother a woman's life, their hobbies, their sexuality, their work, their travel. We just call it QOL, quality of life. So if you're missing work, fatigued all the time, craving ice, starch, eating dirt, pale, hair falling out, shortness of breath, palpitations of the heart, you need to identify these symptoms, especially if you're presenting with heavy bleeding or prolonged bleeding. These are often signs of anemia. And while periods can be a nuisance, they should not impact what we call the quality of life. And secondly, I think part of the exam that's mentioned, the physical exam should be a thorough abdominal exam. Make sure that you have emptied your bladder before the exam. So often you're waiting for doctors in the office, sometimes a little longer than the 5 minutes or 10 minutes. Make sure your bladder is empty. And I think every woman deserves the abdominal exam. And also important to me is a speculum exam. So visualization. Not all bleeding can be due to fibroids. I've picked up cases of cervical cancer, vaginal cancer, prolapse fibroids, prolapsing fibroids or polyps that come through the cervix. So really, unless you have a religious prohibition against being examined during your menstrual cycle, you should expect a pelvic exam, a pelvic exam including visualization with the speculum. And those would be the screening tests in terms of the original things. And I agree with Dr. Cox about all of the labs. But share your story. It's so important. Doctors get busy. Tell us how your periods affect your life. What can't you do? What do you stop doing? What do you wish that you could do? Because again, periods are just there, a nuisance, but should never be truly problematic. So I think stressing your symptoms, even when not asked, these are the things to look for. Additionally, things like pain, visits to the emergency room, taking off of work because of discomfort, not doing things because, like she said, bulk symptoms, having to go to the bathroom every 5, 10, 15, or 20 minutes, looking desperately for a bathroom. That's just not normal for a patient who's still in the reproductive year. So we want to think very broadly of those types of symptoms. And so it's not just when are your periods, how long are you, but tell the story about what those periods mean to you. I have patients crying. They can't stand being on their periods. They're going to have to cancel things. That's not normal. And unless you share that with the doctor, they're not going to know how your periods are, how badly they occur. And sometimes the blood test can be normal, but your story sways us into doing more, treating you potentially differently. And it makes it very convincing that we've got a patient with a problem. So that's what I would say at this time.
That's very helpful. And should the screening be coordinated across disciplines? When do you know if that's necessary? I'll come back to you, Dr. Bradley.
Oh, I'm sorry. So well, it's hard to know. A lot of times doctors, other doctors and nurse practitioners, other healthcare providers, I mean, I like to know that the patients had an adequate Pap test within preferably the last 6 to 12 months. If I can't find a Pap on record or the patient can't show me her Pap, I'm somebody that's got to see the proof. And for me, I will do another Pap test. I want to see myself. The other thing I failed to mention, if you're having bleeding with intercourse, separate from the period, let your physician know. But I would say they're nurses, family physicians, internists, and maybe an ER visit. And I think if you're seeing specifically a gynecologist, a pelvic exam. And I still repeat the speculum exam and what we call the bimanual exam to feel abdomen and pelvis together to see what's going on. So just work at a team. Some things are just redone in terms of the exam. I don't think we've lost any time for that, but we have, you know, an idea that everything is indeed normal. We haven't missed something.
Okay, that's very helpful. Dr. Jones-Cox, would you like to add anything to that question?
Yeah, one of the things that I've seen on more than one occasion is that we attribute anemia secondary just to the fibroids. And while, yes, the heavy menstrual bleeding can cause anemia, there are other sources of anemia that should be evaluated in patient populations as well. So if you have anemia, I also refer you to gastroenterology for a colonoscopy. I've had too many colon cancers that were missed that we thought that their anemia was just secondary to their heavy menstrual bleeding. And they actually had bleeding from the gastrointestinal tract. So it's important to, if we're starting or initiating some kind of treatment, that we're actually seeing an improvement in other indices. If not, we need to ensure that we are also having patients be evaluated for other sources of pain or bleeding. The symptoms of pain and pressure with fibroids can also mimic, deep infiltrating endometriosis and ovarian pathology. So we need to ensure that we, just because of the heavy bleeding, that we don't just focus on that and that we don't miss other diagnoses. And that's when your story, that's what you tell your providers is really going to help us delineate where we need to investigate.
Right. And the thing I forgot is to mention the age of screening used to be start between ages 50 and 55. Now it's 45. And if you have a family history of colon cancer, say if someone's father developed colon cancer in their 30s, or you want to be screened about a decade before. If you are told that you're anemic, and like Dr. Cox mentioned, and your fibroid is treated, however it was treated, it's important at 6-8 weeks later to make sure that those blood counts and iron studies are better if we sort of cured your fibroid related problem, because I agree with her. I have seen patients where we blame everything on the fibroid, and it turns out there's an occult cancer of the colon, cecum, which is a part of the colon, slow amounts of bleeding. So if anemia doesn't get better after true treatment and your periods are better, we need to start looking elsewhere for sure. So I would just add that in terms of need for follow-up.
This is really important information. And despite the fact that when I had a UFE, that was my fourth surgery, and I thought I was prepared for everything. And Dr. Spies did my surgery, and he wanted me to get an MRI, kidney MRI before my UFE procedure. And then he scheduled another one some months after to just make sure that my kidneys weren't impacted by the fibroids or by any other complications. I was very surprised by that, very pleased that he was doing that comprehensive screening. And I also thought about, we hear a lot about endometrial biopsies that are very painful. I've also had one of those by a wonderful gynecologist, and it was not painful. So can you, Dr. Jones-Cox, expand on other health concerns that could be an issue when it comes to being diagnosed with uterine fibroids, that it might possibly be something else, or to expand that screening to just make sure that there isn't something else?
Yeah. Like Dr. Bradley mentioned earlier, not all vaginal bleeding is coming from the uterine fibroid. So starting off with just making sure that your pap smear is up to date and that we're not missing cervical dysplasia or an early cervical cancer. And then with evaluating the endometrium, which is the lining of the uterus, we do an endometrial biopsy to ensure that there's no precancerous or endometrial cancerous cells in the lining of the uterus. And because fibroids are so common, it is not uncommon that someone could have uterine fibroids and an endometrial cancer, okay? And when we're looking at the age range where we're seeing heavier bleeding, whether it be during our 30s or later in our 40s, we need to ensure that we are not missing those diagnoses. Endometrial cancer is one of the most prevalent cancers after breast cancer, and the hallmark is heavy menstrual bleeding, which is the same as uterine fibroids. I know many people have a lot of anxiety and fear about the endometrial biopsy, but it is usually necessary and should be reassuring to make sure we're not missing any other diagnoses.
And I would also just add, we're evolving with evaluation for endometrial health. And I've often said that my hysteroscope is my stethoscope. So we have tiny instruments now that are literally the size of an ink pen, 3.2 millimeters. We're in the office. We can put a small scope in and look at the entire endometrial cavity. It's quick, it's comfortable. Today I did 8 of them in my office. We have a production of just getting these done. It's comfortable. You can visualize the entire endometrial cavity, the cells that menstruate, to look for other things that can mimic fibroids, as she said. Women can have endometrial polyps. These are small growths that can coexist with fibroids. There can be fibroids in the space of menstruation. There can be hyperplasia, which is precancer or actually cancer. There could be a foreign body, something, maybe an IUD that's been forgotten that's there. There are many things. So, I'm currently working with a group. We're doing it's not completed yet, but an international hysteroscopy guidelines to get rid of just evaluating blindly. I think a biopsy is helpful, but when negative, and bleeding is really coming either erratically or heavy, or just you have long history of not having regular periods, PCOS, that puts you at greater risk of endometrial health and endometrial disease, not fibroids. You can coexist. But we're talking about the cells of menstruation. These cells can be abnormal in addition to having fibroids. And so we don't want to overlook that. And women with chronic leukorrhea, watery discharge, secretions, you really want the physician to look in the cavity to make sure that you see no intracavitary. Intracavitary means the space where a baby would be or where your period starts, that there are no lesions. And so I think we're getting more guidelines to say, look directly, just like a colonoscopy or an upper endoscopy or a cystoscopy, where doctors look in different orifices, so to speak, to see what's going on. And so I think you're going to hear more of that. And these things could often be done in a well-equipped physician's office comfortably, allowing you no time off of work. Most of the patients go back to their activities. So you may also want to start asking, depending on your bleeding pattern. I'm not saying this is a screening for everyone, but the use of hysteroscopy to evaluate the inside uterine cavity. And it's very, very valuable to look globally inside the lining of the uterus. So I would add that.
Does adenomyosis fall into this conversation, Dr. Jones-Cox?
So adenomyosis is a condition of within the muscle of the uterus. There can be development of what we call adenomyomas, which are kind of consolidations of adenomyosis, which can look very similar to fibroids and behave very similar to fibroids, causing heavy bleeding as well as painful cycles. So it is definitely part of the conversation, part of the differential when we're looking at causes of heavy bleeding or painful cycles. And the process does enlarge the uterus. So it's a global enlargement of the uterus, not discrete fibroids, but a global enlargement of the uterus that can cause some of the same bulk symptoms that we spoke about earlier, that urinary frequency, pelvic pressure, and pain with intercourse. Yeah, very similar, different mechanisms, but very similar symptoms.
And one more follow-up question. What data do we have on the incidences of gynecologic cancers as it relates to uterine fibroids?
Well, I mean, cancer within the fibroids, that's called a leiomyosarcoma. It happens, but it's infrequent, but should not be forgotten. The current numbers, at least I'm quoting or that I've read, and I'd love to hear what Dr. Cox says, like 1 out of 350 to 1 out of 400. It's more common in Black women in the menopausal years, and my own personal seed of patients, I mean, quite frank and abject, just hemorrhaging. You know, we often say massive growth of the fibroids in terms of the size. It's not zero, but we look at, it's about, that's the number that we're sort of, I think, quoting out. And again, that is different. That's a cancer of the fibroid, and that's different than an abnormality from the cells of menstruation. If someone has endometrial cancer, that's the cancer of the lining of the uterus, and that's different than cancer within a fibroid. So two different kinds of things.
Thank you.
Yeah.
For sharing.
The prevalence, when we talk about the concerns, there's concerns about a cancerous fibroid, but when we look at the numbers, the prevalence of endometrial cancer or cancer from the lining of the uterus is much higher than having a cancerous fibroid or a leiomyosarcoma. And when we look at our risk factors in America for endometrial cancer, which are similar to the risk factors for breast cancer, number one being obesity, okay, and unopposed estrogen, the risk of having a GYN malignancy, it's going to be higher for endometrial cancer than it is going to be for cancerous fibroid.
Right.
Very, very informative. Thank you. And we haven't had this conversation before. And I'm really, you know, I appreciate you providing those insights. And I also want to park another really important point for not just our community members, but for our clinicians watching, which is how important it is to be able to use a hysteroscope and conduct an endometrial biopsy and use a speculum in a way that is not alarming or painful to patients. It sets the tone for future care, and it changes the dynamics of the whole doctor's visit completely. So, you know, when you're in the care of two wonderful clinicians like Dr. Bradley and Dr. Jones-Cox, you have an experienced professional, and that should be the expectation. That's a great this last conversation is a great segue into discussing heavy menstrual bleeding through perimenopause and after menopause, because I think sometimes there's a familiarity with bleeding and it's not really addressed quickly enough. And so, Dr. Bradley, can you expand on heavy menstrual bleeding or bleeding after menopause and what patients should do if that occurs?
Correct. So we define menopause as 1 full year without a menstrual cycle, which menopause can start anywhere from age 40, where it's 1 out of 100 women who stop their period. By age 45, 10 out of 100 have stopped. By 51, 52, 80 out of 100 women have stopped their periods. By 55, 95 out of 100 have stopped. And by 58, everyone stops. So when a woman stops their period, when you have bleeding 1 year after that, not related to stopping hormone therapy or something like that, we call that post-menopausal bleeding. The good news is that most postmenopausal bleeding, 70%, is not from cancer or precancer. It's just that the lining of the uterus gets so dry, frail, and atrophic. But again, we look at development of polyps, fibroids, hyperplasia, which is a precancer. There's several different types of hyperplasia, and cancer. Additionally, as we age, 3% of cancers of the lining of the uterus may be due to ovarian masses, where you have an early ovarian cancer that's liberating chemicals that may impact the lining of the uterus. So it's important to talk about, do you have bloating? Is there a family history of ovarian cancer? Again, bulk symptoms from ovarian cancer, urinary frequency, urgency, early satiety, eating and just a few tablespoons or forkfuls of food and getting full. So we want to be very comprehensive. Secondly, don't minimize the amount of bleeding. Black women, sadly, have a 60% higher risk of death from endometrial cancer than other races. And sometimes it can be due to doctors not listening, patients minimizing symptoms, and some women get to be 65 or 70. They have bleeding, staining, spotting. In fact, I don't ask women if they are having postmenopausal bleeding, because when we say that, women are thinking red blood. I asked, do you have watery discharge? Do you have brown discharge? Is there rust coming out of you? Do you have pink discharge? And the last question, do you ever see anything red? Because if you ask many of my patients, have you had postmenopausal bleeding? They're going to say no, because that pink, that rusty, brown, sticky, gelatinous, they don't see that as blood. So I think it's important to make sure as patients that you know the language. You can say, no, I don't see blood, but doctor, I see this rust coming out of me. I see this brown stuff. I see this tan stuff. So that to me is important. And so again, that the bleeding can be light and it may not come out every day. It may come out periodically. It's not your period. It's because you don't have periods after menopause. And as we age, our cervix is so tight. If we haven't had kids, if we've had a leap, a cone, multiple C-sections, having no kids, sometimes the blood just doesn't come through the cervix and it may drip out, or that drainage may be of a different color. Report anything and let us as doctors be the detective and the workup. Don't diagnose yourself. Report cramping. You shouldn't feel like you're starting a period in menopause. You shouldn't have anything just periodically or episodically leaking out of you. You shouldn't notice something when you wipe yourself or staining on your underwear or toilet tissue. So I think I've become very passionate about stamping out endometrial cancer, because so much of the things that I see is that women and or doctors have minimized symptoms and not worked the patient up with imaging, hysteroscopy, directed biopsies. And I think we can do better if we know, if we're on the same page about language. Words matter, our questions matter, and patients sometimes answer no to blood. But if you asked a different way, if you're a healthcare provider on here or for a patient reporting something, I think that's so important. And that workup should be seamless and quick, and to rule out everything from vagina, cervix, all the way up into the uterus in terms of bleeding. The last thing is, many women will come in and say, oh, it's my fibroids are bleeding. In menopause, your fibroids are present, a passenger, not a problem, usually. And they are hibernating, dormant, and sleeping. They will always be there on imaging, ultrasound, sometimes CAT scan or MRI. That bleeding is unlikely in most cases due to fibroids, but it's to the endometrium, sometimes the cervix. There's a bimodal distribution of cervical cancer. We got to get the pap test. That's a part of my exam. You come in, you haven't, 65, if you're fine, you don't get a pap test, or 70. But you now have bleeding. That's an important part, looking at endocervical cancer and the like. So, it's a lot of things to think about. Let us diagnose you. Don't say it's my fibroids that are bleeding. Just come in and tell us that you're noticing some kind of different discharge, and we look for all kinds of things.
Okay. Very, very helpful. Dr. Jones-Cox, Dr. Bradley mentioned bleeding. Should you have a gynecologic exam when you're experiencing bleeding?
Oftentimes, especially if appointments are acute, you may be bleeding heavily. Maybe you were seen in the ER and now they referred you to see your GYN, and you may still be bleeding heavily. I will still evaluate you during that time. It gives me a good idea of how heavy the bleeding is. I won't be able to do a full evaluation. I won't be able to do a pap smear. I won't be able, usually in the office, can't comfortably do a hysteroscopy if there's a large amount of bleeding. But what I will do is give you medication to help stop the bleeding and bring you back for an evaluation. But there's such limited access to GYN care right now.
Mm.
So make the appointment, be seen, get established with a provider that you trust. And if we can't do the full evaluation during your first visit, then come back for that evaluation. To echo with Dr. Bradley, there are lots of more recent studies that are showing that some of our guidelines for screening for endometrial cancer in women of color are not accurate. Okay, and that points to our role and the necessity of hysteroscopy and not just relying on endometrial biopsies, especially in the setting of postmenopausal bleeding. The outcomes of women of color for endometrial cancer mirror the outcomes for breast cancer in women of color. Higher stages of disease at time of diagnosis, decreased life expectancy, poor outcomes. So it's important that we are advocating for evaluation, for biopsies, for hysteroscopy to evaluate the lining of the uterus to make these diagnoses earlier.
And what I would also add to this, because it takes a long time for our language to change, even ACOG has a pamphlet that says hysteroscopy, a second pamphlet that says dilation and curettage, or DNC. If your doctor says to you, for whatever reason, you couldn't tolerate office exam, they couldn't see or something in the office because of bleeding or your cervix is tight, and the doctor just says, I think you need to go under anesthesia and have a DNC, I think you need to put your hand up and say, wait a minute. You need to ask, are you going to look in my cervix every minute? My cervix, go through the cervix, but look in my uterus the entire time to look so that you are sampling my lining of the uterus. At my hospital, I do not let my residents say that the procedure that we type up, hysteroscopy DNC. Absolutely not. They have to dictate, or I type up, exam under anesthesia, dilation of cervix, visually directed hysteroscopy, visually directed endometrial curettage, visually directed removal of polyps, visually directed myomectomy. You want your doctor to, and you need to know that that hysteroscope is in every second. We don't even use a curette, scraping away with the old-fashioned curette. I don't use it at all because it's not accurate. It does not sample the endometrium and it's blind, okay? If we gave you a paintbrush and covered your eyes with blinders and said, paint this room red, you would miss different parts by blindly not seeing what you're doing. A hysteroscope allows a physician to take fully directed biopsies of the entire lining of the uterus or areas of concern. So I really do think that women need to start asking, doctor, how do you do your procedure? You do not want a physician that puts in a hysteroscope, takes it out, and then just scrapes away blindly. The hysteroscope is a physician's best tool for visually seeing everything, and you want it to be all the time. We have irrigation that we can see clearly, even with all the bleeding that someone has. So I think we are trying to teach this better to our physicians and trainees that are starting now, residents and fellows, but things need to be done continuously and visually with the hysteroscope, and absolutely not blindly. And again, that's that's how we teach at our institution and how we do the procedure.
And what's the formal name for the scraping? Is that the DNC?
Well, the problem is, and if I live long enough, I hope to be like Dr. Cox and others, we need to just stop saying you're going to have a DNC. The problem is we give the patient 2 handouts to say what you're doing, but it really is, it's so wrong. Okay, we need better language for the patients. Right now, all I can say is you're asking your doctor, are you using a hysteroscope? And are you going to take samples the entire time while my hysteroscope is in? Will you ever take samples blindly? You can just ask that. The answer should be no. The answer should be, I'm going to keep my hysteroscope in, and there's instruments that we use to visually take sampling, visually remove an entire polyp. visually remove a fibroid. I mean, there's different things that we put in for the technology through a hysteroscope, but it should always be done continuously. And again, medicine is an art as much as it is a science. Right now, only 28 to 35% of American gynecologists even do hysteroscopy in the office. So I think, you know, there's a lot of learning, a lot of training. This is not difficult for physicians, but you as a patient needs to get if the doctor misses something and tells you, oh, your biopsy's fine, but missed a whole polyp, lesion, focus of cancer, it's not going to do you any good because your symptoms don't go away. So I'm just saying, this is my belief in how we train. And my mantra, like I said, is my hysteroscope, is my stethoscope, because I allow myself to see everything as I go into the vagina, even a vaginoscopy, into the cervix, into the uterine cavity, seeing the beautiful phases and coloration of the lining of the uterus. It's no longer dark. It's no longer blind. We see in living color. Just like if you had rectal bleeding, a doctor can do a rectal exam, but he or she needs to put in a colonoscopy. If you had hematuria, blood in your urine, they're not going to just do a cytology. They're going to look with a cystoscope. If you're vomiting up blood, they're looking with the endoscopy. So the same thing with the uterus. There is a scope that's called a hysteroscope, and that's what we should be using, just like all of our other colleagues that are evaluating for disorders in different parts of the body, and we should be no different. We're just behind the scenes by decades, but many doctors are catching on and doing that. Sorry to be so passionate about this, but that is my passion, and I think we owe it to women to look all the time.
Thank you for that. Dr. Jones-Cox, would you like to add any comments?
I think it's important to realize that the hysteroscopy is the most convenient to do in the office, and we have a robust office hysteroscopy practice. But like Dr. Bradley said, only 20 to 30% of gynecologists have that option in their office due to probably several factors. So hysteroscopy can also be performed in a surgical center. It can be performed in the operating room if your provider does not have the means to perform it in the office. So that's important to recognize.
Yeah, and it's I appreciate those really detailed answers, because you wouldn't believe how many of our community members email us and say they were just advised to get a DNC. And I always think about what Dr. Bradley's had in the past, and we never had an opportunity to really air that really, really useful information. So thank you for sharing that. Thank you both for providing those perspectives.
And a DNC is dead and cremated. You should not have that alone. And I will stand on record to anyone to say that. We have better ways in 2024 and beyond. In fact, for many decades, we've had this device. We just need to get patients asking for it and doctors getting trained to use it and incorporate it into a part of our training. So I think I'll leave it at that.
Thank you. And just for clarification, ACOG is the American Congress of Obstetrics and Gynecology. So last question I have is, what's your advice to patients who are hesitant to seek out a provider for menstrual bleeding concerns? And Dr. Jones-Cox, feel free to add any detail that you advise for military readiness. I know you encounter that a lot under the military system, TRICARE system, for our active service members who may have additional considerations.
Yeah, I think to echo what we've mentioned earlier is that your cycle should be it shouldn't impact your quality of life. And we have to stop normalizing missing 2 to 3 days a month because of our cycle. And just stop normalizing, I can only wear black during my cycle. I'm sleeping on towels. I have to take a change of clothes to work with me. And even though maybe generations prior to you, your mother, your grandmother may have experienced that, we have so many options now to assess the uterus and to treat conditions that we identify, whether it be from fibroids or adenomyosis or endometriosis. So advocate for yourself and to not normalize those symptoms, not normalize symptoms of anemia or fatigue, and to seek treatment. I think sometimes people are hesitant when seeking evaluations, especially with fibroids, because they think the only option may be surgery. And I'm a minimally invasive surgeon. I do complex hysteroscopy and robotic surgery and laparoscopy, and that is my passion. But that's not always the answer for what needs to be done, and that may not fit into your story at the time that I evaluate you. There has been, many newer medications in the market that are targeting treatment of fibroids and endometriosis, which are showing a lot of promise and really allowing people to improve their quality of life. So for my patient population, whether it be my active duty or veteran or dependent population, it's really about one, identifying how your life is impacted, and identifying and you actually recognizing all of these things that we're doing to accommodate our cycle. Whether I block out my calendar, I can't go out of the house, I schedule my leave for that day, um, and to recognize that, and then to advocate for yourself and say this is not normal, and I can do something about it. And then utilizing all the technology, all the medical therapy, whether it be hormonal, whether it be our gRNH analogs, whether it be, hysteroscopy, whether it be hysteroscopic resection of fibroids. There's so many modalities now to preserve the uterus and still treat heavy menstrual bleeding and pain, and preserve fertility and preserve the uterus.
Right.
So advocating and don't normalize it.
Right. I totally agree. I mean, I just had a patient from Australia who told me that in Australia, women are given 10 days a year off for quote period problems. And I'm like, well, they need to come to the US to get evaluated. They have long queues, long lines to get in to be seen. Women wearing diapers. Guys, it is not normal to wear a diaper for your period. I'm just thinking of these large pads. Let your doctor know. And I'm just thinking other things, as Dr. Cox and I have talked. Bleeding, you can have bleeding tendencies from low platelet counts, which are the sticky stuff that keeps you from bleeding, to von Willebrand's disease. Report if you have nosebleeds, gums bleeding, easy bruising, if you cut yourself and it takes forever to stop bleeding, if you've gone to the dentist and you've had, for just simple dental work, a big problem with prolonged bleeding, because these other things can coexist with fibroids, or I know we're not talking about endometriosis, but we look for bleeding from all kinds of places. And then finally, for me, even in 2024, there is still a stigma about talking about periods. We're finally seeing young girls who are proud about having their periods. I forgot the name of the society, but young girls are talking about not being embarrassed about buying pads and things like that. And some adult women and women in the menopause are still ashamed about talking about menstrual cycles. So we still have to realize that there is a stigma. And I agree with Dr. Cox. While I try to do everything in one visit, meaning look to see if there's a prolapsing fibroid or polyp or cervical disease, let your doctor know that you, for whatever reason, you may not want to have it done that day, but we need to get you back within a week or 10 days when your period's over, despite how busy we are, to really take that look. But I do still think that there's a stigma, despite all of the things that we talk about vis-a-vis women's health. We as women have 400 to 500 periods during our lifetime. We use over 11,000 tampons during a period. Lots of money spent on pads and products. Lots of blood is lost, but regenerates each month. But even though this is a cycle of life and a part of our reproductive life cycle, it's still a problem with the stigma. And I still see that where people are I have to pull it out of the patient to tell me about your periods. I mean, can't read your mind. You got to talk, write your things down, bring a friend with you if you're too embarrassed to talk about things, but we have to talk. It's very, very important. So.
Well, thank you. Well, hopefully after having this conversation, all patients will feel a little bit more comfortable, I hope, about really truly discussing their needs and goals with their provider. And I'm glad, Dr. Jones-Cox, that you mentioned other tools in the toolbox, which are medications. I think they aren't discussed enough, and the use of medications has been kind of a slow rolling thing that's taking place because it's not used by a lot of physicians' offices. And I really implore the patient community to educate yourself and ask for what you need, because we always hear from the patient community that there's a fear around treatment and there's so many options. Surgery may not be the best option for you. And it's important to be in the care of a provider that has familiarity and expertise around all of the options available to manage fibroids. Endometriosis, talking about that is perfectly fine because I consider those sister health concerns. Perimenopausal bleeding, heavy menstrual bleeding, post-menopausal bleeding. So this has really been an incredibly informative discussion today. And I so appreciate you. Some of the conversations are a little more difficult to have because, you don't want to consider that being a possibility, but it's important to be informed because the early treatment is really one of the best strategies for overall health care. So thank you both so very much for being with us today. It has been just such a pleasure to hear from both of you, and I'm sure that our community members will appreciate it greatly.
Thank you very much.
You're very
And
welcome.
if I could add one small thing, Dr. Cox and I both failed, at least I failed to mention, you may have said it. Please don't forget the progesterone intrauterine device, or IUD, another solid tool since 1999 that's been available not only for contraception, but for heavy or irregular bleeding and treatment of some endometrial hyperplasia. So that to me rounds out all the things I had on my notes to put down. I just took that I didn't say, but this has been very helpful, and I hope it provides the language for our patients to talk with their doctor and speak up.
Absolutely. Well, again, thank you so much. And we'll look forward to lots of input from the community on this conversation.
Cheers.
Thanks for
Thank
having
you. Okay, thanks for the invite.
Thank you for joining us today for this important conversation. If you are facing a menstrual health challenge, you don't have to make that journey alone. We encourage you to reach out to us at fibroidfoundation.org. As part of our Fibroid Awareness Month series, the Fibroid Maze, please join us on July 23rd, 2024 at 7 p.m. Eastern Time for pregnancy after fibroid surgery, another really important topic. We look forward to continuing to share powerful, informative, and enlightening conversations with you. Together, we are making a difference. Thank you and be well. Thank you so much for joining us during Fibroid Awareness Month for these important conversations. If you're facing a menstrual health challenge, you don't have to make the journey alone. We encourage you to reach out to us at fibroidfoundation.org. If you've missed any of these informative conversations, you can view them on our website, fibroidfoundation.org/events. We look forward to continuing to share powerful, informative, and enlightening conversations with you. Together, we can erase the stigma of silence around women's menstrual health, and together, we can make a difference. Thank you and be well.